Welcome to another episode of the Pediatric Breathing Project. I am your host, Dr. Piya Gandhi, and I am here today with my good friend and colleague, Courtney Scaggs, owner of Space City Speech here in Houston. And she is going to be chatting with us today about all things speech-language pathology, myofunctional therapy, and how we collaborate in treating pediatric patients for airway disorders. So welcome. Thank you so much for being here.
Thanks for having me.
So tell us first a little bit about yourself, your practice, kind of what brought you into the field of speech, but also then myofunctional therapy and airway and tongue ties and all the things that we do.
So I feel like I have a unique kind of pathway to myofunctional therapy. A lot of people that I meet that are in this field kind of came to it later in their profession or through personal experience. But for me, it's something that I kind of fell into right after grad school. While I was in grad school, I was exposed to it. I moved to Texas in 2017 for my last externship of grad school. And it just so happened to be with the president of the International Association of Orofacial Myology. She was my supervisor.
That was Christy? Christy got him. Okay.
It's a crazy story how it all happened because, my original externship fell through and then it was calling people and just
That's crazy.
Randomly ended up on her phone line, had no idea who she was. And she took me on within 2 weeks of me moving here, which is crazy.
Wow.
So I think it was meant to be.
Yeah.
But did my externship there, so trained under for that last semester of college, and then moved on and did my clinical fellowship there, and then immediately started working towards my certification of orofacial myology after that. So.
And what does that entail, certifying yourself in?
It's changed since I originally did it. I started it in 2018, so the process has definitely evolved since then, but when I did it, I had to take my 28-hour introductory course. So I went and did that in Napa for my birthday with Christy, which was great. And then I had to we have about 2 years to do like a 50-question multiple choice test and 10 questions that are written essay style. And then from there, if we pass that, we have an on-site visit, which I did at your office.
Yes, I remember that.
So a full day of someone observing us with pediatric and adult clients, giving us feedback. We have to submit like lots of info before that about the patients that we're going to be seeing. It was a pretty intense process, and I took the time kind of to see patients, learn what I was doing, really get in depth with it.
Yeah.
A lot of people go through it and finish it in like 2 years, but for me, I stretched it out, and it took me about 5 years to finish the whole process because I wanted to feel like I really had a handle on it for when I finished.
Yeah.
So by the time I did my on-site, I was like super confident in what I was doing, and I was like, oh, this is easy.
You've been doing it.
Yeah, but it definitely is because I kind of took my time on everything, and COVID didn't help either.
And just to touch on, not all people doing myofunctional therapy have this certification. Is that correct?
That's correct.
Okay.
And there's lots of different certifications out there for myo. For speech therapists, myofunctional therapy falls under a scope of practice. So as long as you are sufficiently trained, that's what our scope says, then you are good to practice.
Okay.
So there are tons of incredible myofunctional therapists out there that don't have any certifications. So it's more about just like connecting with them, seeing what their skill set is, seeing how comfortable they are delivering therapy. But yeah, for me, it was just kind of deepening my practice and learning more about it. So definitely not necessary. I'm glad that I did it.
Yeah. So in your practice, what all, I mean, it's not just you have now a team of therapists. So what does your practice provide? What age ranges do you see? Just kind of tell us a little bit more about your kind of day-to-day and your team.
Yeah. So we've had a lot of growth this year. Yes. This has been a really crazy, unexpected year for us. But we have a team of 7 now.
Amazing.
And they're
Congratulations.
Thank you. Thank you. And they all have very specialized kind of areas that we work in. For speech therapy, we have 9 areas that we are able to treat, plus myo. That kind of goes into the feeding area for us. And I would say on our team, we cover about 7 of the 9 areas. We have someone that specializes in cleft palate and augmentative communication devices. We have someone who specializes in stuttering and cluttering, which is amazing. We have someone who specializes in feeding. We have someone who specializes in autism. We just have kind of a wide range. But we currently have myself and 2 other therapists that are doing myofunctional therapy on our team. And they also have their own specialties.
Yeah.
One of them has an RDH background, so she does only myofunctional therapy, no speech, no feeding. And then our other therapist does speech, myofunctional therapy, and feeding, which is great. So really just wide range of things we see. Amazing. 6 months and up.
Okay.
But for the 3 and under population, we're really only seeing language right now. For those little ones, we're just referring them to someone who that's their specialty.
Yeah,
so.
Sure.
Yeah.
And as a parent, how do you decide who, like, do we see a speech language pathologist? Do we see a myofunctional therapist? Do we see a feeding therapist? What are some of the things that, as a practitioner, you would look for to direct them to the right type of provider?
So the question that I always ask on our intake is, are there any speech or feeding concerns? That's like my first line of defense. And if that's a yes, then they go with a speech therapist.
Okay.
If they say no, then, I kind of ask a few more questions and see, have there been any history of language delays? Are there any coexisting conditions? What's your diet like currently? Because sometimes they're like, no feeding concerns, and then we get in there and they're only eating canned food. So I'm like, oh, there's something else going on. So and one of the nice things about our practice is that if you end up with someone that's not the right fit, we have the flexibility to move you around.
Yes.
So it's like some of our patients will start with myo only, and then our myofunctional therapist is like, I think there's something speechy going on here. So they finish myo and then start speech. So
that's great as a parent, the convenience of not having to switch practices. And obviously this is a podcast that focuses on pediatric airway, and we're speaking with you as a speech language pathologist. So how is this how are all these things connected? Because I know most parents are going to say, well, how is a speech language pathologist connected to an airway at all? Just like they question that with dentists. But I would love for you to explain how all of this is connected and your role in pediatric airway health.
Yeah. So I would say one kind of thing before we jump all the way into that is our team is really good. Even the ones that aren't fully myo trained are really good at identifying when something is myofunctional.
That's great.
So if they start traditional speech therapy and they're like, they sound really just like back of the throat, stuffy. I looked at their tonsils. They're huge. Like, I'm going to keep monitoring them, but I just want to put it in your brain that there might be something myofunctional going on here, and then we will get them transferred over to someone that has experience. But we definitely see impacts on voice quality and speech sound quality based on airway concerns. A lot of our kids that sound really stuffed up, that impacts how their speech is coming out. They sound like they're kind of talking through a muffled, like something is over their mouth almost, but it's just their tonsils.
Okay.
And then the other big impact that I see airway wise is with narrow palates, especially with R. That is like the most specific sound that I hear. And I look in, I can see it's narrow. Our tongue needs to stabilize inside of our back molars to make a really sharp R sound. So a lot of times if there's not enough space, it kind of hits on the bottom sides of the teeth and creates just that softer, almost valve-like sound.
Yeah.
You also see it for, it sounds like SHCH, where the air is escaping over the sides, like a lateral lisp, that flushiness.
Yeah.
It's not fitting in there as tightly as it should be. So.
And what about, like, from a tongue tie perspective? How does that impact speech sounds and what you're dealing with?
Different ways. And it kind of depends on, where if it's a posterior tie versus an anterior tie. We use our tongue to make all sorts of sounds. And a lot of times we'll see higher palates with tongue ties. So they're having to bridge a really big gap to make speech sounds like T's, D's, K's, G's, depending on where the tie is. And sometimes they just can't. They just don't have the structure to support the function that we're looking for.
Yeah.
So we try a lot of traditional therapy first, and if we're not seeing progress, then that's when we're like, it's time to look into the structures a little bit more.
And I'm all about trying therapy first. I think that really discerns like what we need to do next. But what I do see, the pattern that happens is that sometimes therapy will go on for months and months, years and years, and they've been plateaued. And, my concern is obviously burnout, but also whatever we're doing is not enough. So this is probably more patient specific, but let's say I'm a parent, my kid's in therapy. How long am I sitting on a plateau before I look into something else? So as a therapist, if you see like how approximately how long?
I mean, during our evals, I tell parents, let's try this for 2 to 3 months.
Okay.
And if there's no progress being seen at that 2 to 3 month mark, that's, 12-ish sessions with a cancellation here or there. Something is going wrong. Sometimes it takes those 12 sessions to establish rapport,
Sure.
start to create the basis for the sounds. But at that point, we should be seeing progress. And our practice doesn't have a lot of lifers. We want kids to be graduating. We're doing evals every year if they're not making progress. There's a few one-offs that really need some additional support, but kids aren't lingering around our practice.
And I think you bring up a good point. Therapy shouldn't be for life.
No.
And I think that is a misconception because I have seen many kids that have been in therapy for years. First of all, that's a huge expense and a lot of time commitment and, a lot of effort on these kids. But therapy is supposed to get us to the next level, and then we're supposed to move on. So if it's not doing that, we either need to change the type of therapy or look into something else. So I love to hear that, that perspective of your practice in general. Along those lines, when should a person start therapy, or I should say a child start therapy? Because I'm a proponent of, if we think there's something going on, let's just go get a consultation. As opposed to what I hear from some parents is that, their pediatrician provider is saying, well, let's just wait to see if they catch up. So obviously it's individualized. There's this discrepancy. I see this more with speech delay on the little ones when they are not saying the right number of words. So if you could give us a quick ballpark of, by this age, we should have generally this amount of words and things like that, and what parents should be looking for.
It's a lot. And I will say, I, on our Instagram, have broken down all the milestones by age.
Love that.
Because it really changes rapidly. And I even like to look at the pre-language skills, so even before that first word is being said.
Like the cooing and that's
why we work with kids as young as 6 months, because we're working with kids who are not yet babbling, not yet imitating actions. There's things that come before language. So we're looking early.
When I see a silent baby, I'm like, that's a red flag.
Let's get into what's going on. And we are also very much the team of not wait and see. We would rather you come in, get an evaluation. You're going to either leave with a full plan or peace of mind.
Yes, I totally agree.
And you can always come and do it again. I tell families that if you come in at 11 months and everything's within normal limits, you can come back in at 2 years. It's okay. At least we also offer screening. So if you're not willing to jump into the full evaluation, you can meet with me for 15 minutes. We can talk about it. I can do a formalized screening if you want, but oftentimes
I love that.
Talking through milestones and being I would recommend further assessment, or I think you're probably on the right track. But a big thing is we should be hearing words by 18 months. If there are not true words by 18 months,
red flag.
And that is the time that I would definitely intervene, because after that, it just snowballs.
Yeah.
The expectations for 18 months and forward is crazy. Things change so fast in that last 6 months before 2 years. So that's when I would say is a really good time
18 months
to check in. And that's usually when pediatricians are thinking about benchmarks as well.
Yeah.
But we'll see even earlier. So just referencing all those milestones by age and kind of looking at what your child has, and if they're missing one, I wouldn't panic.
Yes.
But if they're missing 2, 3 of their milestones or never met ones for the previous age group, probably
starts to snowball, like you said. Okay, awesome. And how do you see oral habits play a role in speech development and oral development? What are some things in your practice that you do to help parents eliminate those things? What are your recommendations on when they should be eliminated?
So oral habits, to me, when I see them, it's an indicator of something deeper. So I think it's functional for me to know that those things are going on, but when I see them, it's not just, oh, this is just a habit, a routine. There's something else going on. So it kind of signals us to look further.
Okay.
We see a lot of speech impacts with extended thumb sucking, extended pacifier use, anything that is in the middle of the front teeth. It ends up opening that gap in the teeth a lot of times, and the tongue's used to going forward and back. So it's just pushing right into that gap. And that's where we see things like lisp occur because the tongue's in between the teeth. We kind of approach it from a few different ways. We try and get some more functional oral input, like chewing and the molars. And we also kind of try and do elimination through positive reinforcement. So we'll get out like a full poster and trying to start small. So the first small prize is after 2 days. No thumb sucking. And I've even had to scale it back before where we can't just get through the afternoon. They try the afternoon for a week and they can't get like through that after school place. So individualizing it for each client, but slowly building up small, tiny rewards over time.
Do you use any adjunctive things like bitter essential oils on the thumb, or things like Myofunctional?
Use a lot of Myofunctional.
Okay.
Use a lot of chewy tubes too.
Chewy tubes, yeah. Any thumb guard, or you don't do any of that?
I don't recommend that. That's not my first line.
Okay.
I've seen it be effective at nighttime if they can't get past that kind of barrier.
Okay.
But I always start from a positive reinforcement place first because I want it to be a fun, functional, motivating thing. And trying to find the right time to do it is really important too. I think a lot of families think, oh, we'll just knock this out over Christmas break. And I'm like, there's so much
going on.
There's so much chaos. Like, that is when your child is probably going to
need it the most.
Right.
Yes.
So trying to find times where it's kind of calm. I always also ask the child if it's something that they want to eliminate because I need them on board. I can't eliminate a habit that someone doesn't want to get rid of. So trying to make sure there's intrinsic motivation as well. And usually they're ready. Like, we do a lot of that habit elimination at the 4 or 5-year-old and they're ready. They don't want to do it at school anymore. Like, they want it gone as well.
I am just curious to hear your thoughts. And I have a feeling I know what you would say, but in school, for example, and I don't use these, but we were taught to put in one of those thumb cribs.
Mm-hmm.
And same for like the thrusting habit that comes from, prolonged thumb sucking. What are your thoughts on something like that?
They have a very specific use, and that is to stop a habit, which is great in theory, but it doesn't teach the correct habits that should be happening. It doesn't teach the correct resting posture. It doesn't teach the correct swallow pattern. So when I see those, and I often see, well, the thrusting has stopped, but now we're compensating in other ways. Our area's escaping from the sides. We're just having something different going on. And we really focus in our practice on trying to keep things very positive when it comes to the mouth. Because, we want our kids to feel comfortable with us in there, then moving around. We don't want it to be a scary experience. And something like that
can be. Yeah.
So not my favorite. Yeah. It's not something I would ever personally recommend, but I do, see people in my office with them, and we make that work.
And I think this is like important for dentists to hear, because this is what we were trained to do.
Sure.
And the thing we were not trained to do at any point was collaborate with a speech language pathologist or myofunctional therapist. Yeah. It was just, we have to talk to the parent and figure out how, to use a thumb guard or yucky nail polish or this crib appliance. And, at least in my experience, these kids sometimes are hanging on to this habit because things are not working well. Like you said, it's something deeper going on. Mm-hmm. Either the tongue is not working well and it's not sitting in the roof of the mouth like the thumb or the pacifier is. And I'm going to say this, and you're going to want to kill me because we talked about not talking about body work. But when I think about habits, that's also a nervous system dysregulation. And so what we do in our practice is, yes, we refer to you because we want the tongue moving correctly and getting that up in the palate and getting the positive reinforcement from eliminating the habit. But we also incorporate the body work to help regulate the nervous system. And this kind of touches on how even something that seems as simple as a thumb sucking habit that parents think they're going to knock out takes a team approach. It's not just me. It's not just you. It's not just the body work. It's not just the parent. It's like all of us working together. And you also touched on, we need the kid on board too.
And sometimes I'll bring in occupational therapy.
Yeah.
So if I'm seeing it's a sensory seeking thing, but then I'm seeing full body sensory seeking, then I'm like, oh, this might not be about the mouth at all. This might just be a piece of a bigger puzzle.
Yeah.
So there's been times I've seen like lots of sensory seeking, crashing, jumping, all of that, and also thumb sucking. And I'm like, let's get OT.
And it's all,
all of these things under control.
Yeah. Do you have any go-to OTs that you work with here at Houston? I would love to hear who they are.
Great ones. Lizzie Simon in the Heights with Sensationally Thriving. She is incredible. She's great at collaboration, and I love her. And then the team over at Children's Therafund, especially Lauren Evans. She is great. I know she's very full these days. She's very popular.
That's what happens with the good therapist.
I know. And she's a great handwriting therapist, which is completely different than what we're talking about. But it's nice to kind of have her for different things. So she's a great
Okay, very good to know. And all of this just touches on the fact that we have to use a team for all of these kiddos, whether it's speech related or feeding or airway, because the reality is they're all kind of connected.
Yeah.
And so what I love about working on a team is the different perspectives and different eyes that we see on the same kid. Talk to me about your, when you see a kiddo with an airway disorder or the large tonsils or the feeding, how do you organize a team?
Yeah, it's a great question. I kind of say that as speech and myofunctional therapists, I feel like our job is to come up with a plan, because we are pulling like lots of different things. We're looking at speech, feeding, swallowing, and sleep. Like, we're able to look at all of the aspects. And so from there, we can make recommendations about who you need to see on your team. We have a section in our reports that's like consult with an airway-focused dentist, consult with an airway-focused ENT, whatever it is, we have that in there, and that's part of our recommendations. It has helped us learn to be more flexible in how we do treatment. I think as speech therapists, we're used to being like evaluation, treatment, dismissal. That's like the normal path of things.
Yep.
But when there's myofunctional or structural concerns, it's never straight and narrow. Like, a lot of times we'll do the evaluation, start treatment, they go into expansion, take a break, we pick back up right after, and then we finish it out. We do some myo, then we do some speech, we do it at the same time, and then it's dismissal. So it's definitely, we've learned to be more flexible with kind of our timelines there, for sure.
Yeah. No, and I think flexibility is just the word in pediatrics in general, especially with more and more of these collaborations happening, because I know, on the ENT side, like sometimes we'll start expansion and then we need to address tonsils and adenoids. The great part is a lot of the ENTs in Houston will do the removal with the expanders still in, which is huge. And that way we're not totally interrupting treatment. But one thing is, and the expanders that we use in general have a lot of coverage in the mouth. And I know it can impact speech even more. So, I tell parents, we might make things a little bit worse before we get better.
Yeah.
I'm curious from your standpoint, for the kiddos that you've seen start with speech, go into expansion, and then come out and pick up, what that trajectory looks like for them.
It's quick. I mean, a lot of them are a little bit on the older side, so they kind of getting that little bit of knowledge before they go into expansion. They start with a really strong base when they come out, so it's not like we're starting from scratch. Like, they have a base, they know where their tongue should be, they know how their sound should sound. And then with the little ones, like, we're still able to do speech if expansion is in, if it's certain sounds. Like, if they're working on P's, B's, M's, anything with the lips, we can still keep going, keep doing speech. Same with language. There's things we can work on a lot of times, with expansion still in. So it's really, people ask all the time, like, can we keep doing speech with expansion? And it's very much case by case.
Okay. Yeah.
Type of expander, goals, kid, all those things.
Yes. You touched on this just a little bit now with the certain speech sounds, but we've talked about tongue tie, but how do lip ties play a role? if they do?
Yeah, very rarely do I see lip ties have a role in speech. Sometimes I'll see them in feeding, like difficulty clearing a spoon with your lips if you're seeing your child use their teeth or flip their spoon over all the time to try to clear. Very rarely do I see it come up in speech sounds. It just seems to be more of a feeding impact. And when I see something that physically I'm like, oh, that looks maybe a little tight, but I'm not seeing any functional speech or feeding impacts, that's when I really like referring back to dental professionals. Because I say, oh, I'm not seeing any functional impacts on these two areas, but there could be lots of functional impacts from a dentition point of view. Like I always reference when I got my lip ties released because I was having gum recession. So there's so many things that are outside of my scope of practice that still need to be covered. So that's when I flip it back.
And this is where the team looking at it from two different perspectives, because when I contact our functional therapists, I want to know, is this impacting function? From your perspective, because I'm not looking at speech, I'm not looking at feeding. I'm not really taking a deep dive in the myos sector either. And so then we get everyone's perspective. So we're treating appropriately, not over treating or under treating either. From a tongue-tie treatment standpoint, what does pre and post-op therapy look like?
It's very individualized. I know I feel like a broken record that I keep saying,
but it is true.
It's very individualized, and that's something that our practice really prioritizes is individualized care. Some kids don't need a lot of prep. They already, have desensitization on their body. The families just need to be taught exercise and resting posture, and they pick it up really quickly. Some families need a little time. So we really caution against saying like specific timelines for things before we get started, because it's hard to predict what things look like. But we do have some kind of benchmarks that are important to us to be met before we're like, you guys are good to go for this. And one of the biggest ones is not even actually about like how the exercises look, but it's just that they're being done. That the family has time to do exercises every day, that the family is able to incorporate that into their life and they're ready to take it on. They understand what's expected at the end of it. We also want the child to feel very relaxed and prepared for the procedure. A lot of it is not even physical work, but just talking about what's coming up. Kids have so many questions. I'm never shocked when they have these really intense questions about what a release is going to look like. They're really inquisitive.
And they have no filter, which is great.
So they're like, a laser. They're always so curious about what's going to happen. So we spend a lot of time talking about what that's going to look like, drawing pictures of what it's going to look like, reading Catherine's book about what that looks like, just like prepping them for this experience. And then of course there is the like functional prep of making sure
they're ready,
like physically. But it's more than just, I think a lot of times families come in and they're like, okay, we're here for the stretches, or we found these on YouTube. But it's way more than just stretching. For readiness. And then after is the same way too. We're looking at kind of how the wound's healing, talking to you about how it's healing, making sure kind of troubleshooting things if they're having pain or if they're feeling uncomfortable, if they're worried about how their speech is sounding, just kind of talking through those things. And then also working on exercises for healing and function.
And if there are any dental providers listening, as a speech language pathologist, what are you looking for in a provider when you want them as part of your team?
That's such a good question. First and foremost, I'm just looking for clear communication. That's one of the things I like about your office so much, is that I know that I can call and I can be like, can I talk to Dr. Gandhi? And I know you'll call me back. Like you're not hard to get a hold of. And I also know that you're going to be honest with me. If I send someone to you that's not ready, you're going to tell me, which is huge, because it is like our professional practices that are on the line for these things, and I don't absolutely take a risk. So if there's something that needs to be done, I would rather the provider be honest with me and tell me. It's not going to hurt my feelings. Sometimes we miss things. We're all human.
Absolutely. I'm the same way.
So I appreciate that kind of honest line of communication. And I know on the flip side of that too, if I call you and I'm like, what? I don't think we're ready for all of this, that your office is going to accommodate. They're going to reschedule. They're not going to be upset that they're not ready. Like, there's just open communication there. Also, just making sure that they are working with myofunctional therapists and speech therapists. It's always, a little concerning to me because anytime I get a tongue tie release, I'm calling the provider to get more information. I'm asking, what their post-op recommendations are, what they're using, everything. When their follow-ups are, I want to know the whole thing.
What are your thoughts on sutures?
I think it's appropriate. I think that it's appropriate for certain patients and not for others. Once again, it's just kind of a case by case of what they need. There's a lot of clients that we see with extra support needs that really need extra support when it comes to healing of a frenectomy. So I think it's another thing where it's case by case. And that's another question I always ask when I call is, do you do sutures at all? Because, some offices, absolutely not. Some, sometimes. But I feel like that's really important for me to know. And I also want to know if they're going to touch base with me afterwards. Do we finish and I'm never going to hear about this patient again? Is it continued collaborative care? So those are kind of the things I look for with providers. And I honestly just want someone that's confident, when they're talking to me, if there's saying a lot of, I don't know, or I'm not so sure, we'll do it if you want. I want someone that's going to tell me, we do this because X, Y, Z.
Yeah. There's a process and a system.
Reasonings behind things. Yeah. So those are the things I look for.
Cool.
And I'm pretty picky. My patients mean a lot to me, so we want them to be in good hands, and we're lucky that we have great providers here. But
yes, Houston has a great network of people, so it is, and it still doesn't seem to be enough for the number of patients that need this type of care. Any final thoughts that you want to share with our listeners, parents, practitioners, whoever?
I would love to just give a little spiel about Space City.
Please.
I missed that at the beginning.
Go for it.
But we are a practice that I kind of created to meet a need. So we're a community-based practice. We have an office here in Houston, but we also see patients virtually all throughout Texas. We do in homes, in daycares, in private schools, kind of all over the place. And when we're doing myo in daycares or in private schools, we actually have the families come and meet us. Because myo doesn't really work if it's isolated without caregivers there, but the schools we work with are great, and they allow caregivers to come in and support the clients. But our kind of philosophy is just creating these confident communicators. We want everyone to go out there and be able to communicate confidently.
We love working with you, and thanks for spending the morning with us as well.
Thank you.